Welcome to our fourth part in our 5-part lecture. Today's lecture is going to be on benign breast. So what we need to know about benign breast before you even get started is what qualifies as benign criteria. So we're going to talk about what do the lesions look like, what usually leads us to believe something is benign. Once we can kind of define what benign versus malignant characteristics are, then we can decide, do we follow this? Maybe have a patient come back in 6 months, in a year, or do we need to biopsy it to get that definitive diagnosis? Remember, you have to have a biopsy to get that official diagnosis. We can't just look at something on ultrasound and be like, yep, that's benign, see you later. But we can utilize these characteristics to make a very educated guess on what we are dealing with. So the first thing we need to assess is the echogenicity of the lesion. Is the lesion anechoic, hyperechoic, or isoechoic? If it's any three of those, it's most likely benign. In our examples here, this picture on the top here is a simple breast cyst, 100% benign. This example here is most likely a fibroadenoma or a lipoma. And this one here is also most likely a fibroadenoma. The other thing, and you're going to see this in the next few slides, notice the shape. They're all oval. Notice their encapsulation, well encapsulated. These are all clearly benign structures. Margins. What do the margins look like? Benign features include smooth margins, margins that are well encapsulated, or have broad lobulations. So here again we can see almost this capsule that runs around this lesion. That's an encapsulated structure. It's also very smooth appearing. So that right there leads us to believe that this is going to be a benign finding. This one is a little bit scarier looking. It has some more features to it, but these are very wide lobulations. When they are broad lobulations, that is more benign breast pathology. We're going to learn that microlobulations lean us more towards malignancy. But if they're kind of big, fluffy bubbles, then that's going to be that broad lobulation, more likely benign. Again, we have smooth borders, well encapsulated. There's something inside of this one, so that might be a little concerning, but we have other features that make us believe this is going to lean more benign. And then the shape. What is the shape that the lesion is taking on? Is it round or oval? That's most likely benign. Is it wider than tall? Also most likely benign. Now when we talk about wider than tall versus taller than wide, which leads malignant, wider than tall means that the widest portion, like this one here, is parallel with the breast tissue. It runs with the breast tissue. So this one is definitely wider than tall. In contrast though, we have an example here of a structure that's not round or oval, has really indistinct borders, kind of sharp edges, and look at it's taller than wide. It is invading through the different layers of breast tissue. And this one is most likely going to be malignant. So any cancer is really in the body. If the structure is parallel, goes with the tissue that it is residing in, it's most likely benign. When you have a structure that is invading cross-fascial planes, invading through tissue, that's most likely going to be malignant. All right? This wider than tall, taller than wide concept is a key one for understanding breast pathology. Some other characteristics that we might see with our benign breast pathology are going to include mobility. When you palpate the area, does it move around? Cancers are usually fixated within the tissue. Remember, they're growing into the tissue. They're not sitting in or on tissue. So benign characteristics mean that it's going to be mobile. It'll kind of move around. It'll be wobbly underneath your finger. Under ultrasound or even under just clinical evaluation, can we compress it? Is it squishy? Again, benign characteristics tell us that it is going to be squishy. It's going to smush down under some pressure. Cancers don't smush. And then when we put Doppler on, is there any vascularity? And typically with benign pathology, we are going to see little to no vascularity, with the only caveat to that being if there's an infection, if there's like an abscess or mastitis. So let's look at some of our pathologies a little bit more in depth. And what I want you to notice is that I have a lot of benign pathology information for you to understand. A lot of it can be related back to a certain age group, to maybe a certain ethnicity. And I have pictures here with each of the pathologies just to kind of give you that visual person in your name. Maybe we'll call her Cindy Cysts. And she's young and she fits all of the clinical demographics and history for a patient that is most likely going to have breast cysts. So I'm just trying to give you that visualization of a person that could have these pathologies. Now I went very in depth into benign breast pathology. You'll see when we get to malignant pathologies that I don't go as in depth. And that is because unless you work in a breast center, you're probably not going to see a lot of the malignancies. Now the benign breast pathology might just be a random lump or bump that somebody needs image, especially if you work in a smaller healthcare facility. And so you might, or probably are going to see a little bit more of these benign breast pathologies versus those malignant ones. And again, the malignancies, we don't even know what they are until we biopsy them and get that definitive diagnosis. It's very hard to tell just on seeing it on ultrasound. So again, the benign breast pathologies, I do want you to know a little bit more about. I want you to know that family history, what the patient is feeling clinically, and then what it looks like by ultrasound. And then again, as you see, when we get to malignant pathologies, you'll just kind of have examples and pictures of the different malignancies. Okay, so our first patient here has cysts. They're going to be asymptomatic, or they might have something that's palpable. You know, we're supposed to do monthly breast checks, feel around on the breast, feel if there's any changes, feel if there's any lumps. And that's typically when somebody is going to find a cyst on their breast. So they'll come in with a palpable lump. They're usually on the younger side, so we might just do ultrasound first. If they're in that later age range, in that 40 to 55, then they might need an ultrasound to go along with their lump. And most of these patients are going to be premenopausal. So there's still a lot of hormones running around that are making these cystic changes. So here we have that simple cyst. It's going to follow the rules as simple cysts do all around the body. Smooth-walled, anechoic, with through transmission. Now there are a couple versions of the simple cysts that become complex cysts. And these are still benign, but now they kind of look a little abnormal compared to what we expect to see with our simple cysts. And so we can have hemorrhagic cysts, again, where blood is flowing into the cystic area. It's bleeding in on itself, so it's filling it with blood. The hemorrhagic cyst is going to take on a different appearance depending on the age of the blood. Galactoceles are milk-filled cysts. So here we have a cyst with some debris in it. If this was aspirated, we'll probably get out kind of a milky substance out of this one. And that would be our galactocele. And then you can also have sebaceous cysts, which again are kind of plugged sweat glands, usually filled with kind of debris and sweat and that kind of junky looking stuff. So all of these can be complex cysts, but they are benign. And then we can go back and use some of our other secondary characteristics to help us believe that they're benign. You know, these are all oval. They've got round lobulations. They have that through transmission. They've got a lot of things going for it that still lean benign. Fibrocystic condition. This is the most common disorder of the breast. So a lot of women between the ages of 20 to 40 have fibrocystic breasts. And what fibrocystic breasts are changes to the mammary layer due to the proliferation and reabsorption of breast tissue. So that breast tissue is growing and then it kind of reabsorbs itself. On that reabsorption part, it turns kind of cysticky. So when we put the probe down, we're going to see lots of little cysts within that glandular layer. Now these patients are going to be mostly asymptomatic. They might feel some palpable lumps that get larger or smaller with their cycles. And they might also have cyclic breast pain. Again, estrogen plays such a huge role in so many factors of the body that when the estrogen is increasing as our endometrium is increasing, it's going to cause a lot of our sex organs to vary what they're doing, and so we get that cyclic pain along with it. Age range is usually between the ages of 20 and 40, so these are going to be our younger patients. And here's an example of the fibrocystic condition. Again, we have all those layers. Every time you see a picture of breast, kind of go through your mind, can you see where those layers are? But here's that mammary layer, the glandular layer, and we can see that it is not as homogeneous as we would expect. It's actually kind of heterogeneous, but it has these small cystic spaces, leading us to believe that this is fibrocystic change. Again, we have a chest wall here, retromammary, so we're really zoomed in on that glandular layer, but we can just see lots of tiny little cysts within the glandular layer. Now, fibroadenomas are also a very common finding. They are more common in African American women, and this also affects younger patients, so in that 20 to 40-year-old range. Fibroadenomas are basically just a reorganization of breast tissue. They are the most common benign breast lesion. And these also respond to estrogen. So sometimes we will see pregnant women who have a quick growing fibroadenoma that becomes more apparent with their pregnancy. So kind of the same idea with fibroids in the uterus. Those respond to estrogen as well. So these are just, again, reorganization, overgrowth of the stromal and epithelial cells in the breast. As far as clinical symptoms go, these patients are going to have a palpable lump. It's typically painless, and it's going to be very mobile. So they're going to be able to move it around. It's going to be wobbly underneath the palpation. And here's our examples of a fibroadenoma. So these look kind of scary right at first, but if we stop and think about it, we've got a nice roundish oval structure. It's parallel with the chest wall. It's well encapsulated, all benign features that we're seeing here. So with the fibroadenoma, we see that they typically have very smooth walls. They are hypo to isoechoic with the breast tissue. And they might have a little bit of shadowing, but usually they present with a little bit of posterior enhancement. Lipomas then are an encapsulated tumor of mature adipose tissue that usually arises in the pre-mammary layer. Remember that the pre-mammary layer is mostly fat, so it makes sense that our lipomas pop up in that area. Again, these are going to be pre-menopausal women. Anytime that the breasts could be functional, there's lots of changes that can happen within that time. The estrogen is playing a big role. These lipomas can pop up, and they're going to be in our later population in that 35 to 55 age range. So here's an example of our lipoma. Again, skin line, pre-mammary layer, glandular layer down here. So we're seeing that lipoma up in that pre-mammary layer. Now the lipomas are made of fat, so it kind of depends on the true composition of the lipoma, but this one is a little bit more hyperechoic than the breast fat, but quite often it is the same echogenicity. It's isoechoic to maybe just a smidgen hyperechoic to that breast fat. It should be compressible, so if we were to squish down on this, it should change shape, and we do sometimes see some posterior enhancement behind them. But again, look at it's round, it's oval, it's got smooth borders all the way around, and it's parallel with the breast tissue. Now, fat necrosis is one of those benign things that is going to look like cancer. And what is going on with fat necrosis? There's usually been sort of trauma to the breast, and the breast tissue dies in just this kind of like little focal area. And when things necrose, they start to look a little bit worrisome. So again, it usually happens due to some sort of trauma. Maybe it's a car accident. You have seat belts that go across the chest. They may have had surgery on the breast. Any sort of trauma to the breast usually results in fat necrosis. It will present itself as a palpable lump, and it's more common in older women. So here's some examples of fat necrosis. And we can kind of see why these were a little bit more worrisome. These don't really follow our benign characteristics. We've got kind of thick borders, we've got kind of a mixed heterogeneity, we've got lots of shadowing coming off of some of these spots. If you notice though, a lot of it is edge shadowing. It's all edge shadowing off of these areas. Cancers typically will have just this dark band of shadowing straight from the middle of it. So fat necrosis is probably one of those things that is definitely going to get biopsied unless we can pinpoint trauma to the area. Then we might be able to call it benign, or we might just follow it up in 6 months because an area like this should begin to heal. But this is probably one of the more worrisome appearing benign lesions. It's not necessarily a worrisome finding. Now, mastitis is something that I do really encourage you to make sure that you understand. As a general sonographer, if you work somewhere that has an ER, mastitis is usually the only thing that you will scan from the ER. Any palpable lumps through the ER, any significant breast changes that come in through the ER, the radiologist isn't going to want to read them. They're going to want them to follow the proper channels, which is the diagnostic mammogram, ultrasound to follow, before they do any diagnosing on the breast changes. Mastitis, however, is typically seen with women who are breastfeeding, and it's really pretty easy to diagnose just based off of clinical symptoms. The breasts become very engorged and large, so very painful. There's swelling of the area, and there's usually this patch of warmth and redness on the breast that you can see. The patient is also going to have a fever and an increased white blood cell count. So there's just a lot of clinical indications along with the history of breastfeeding that can get you to the diagnosis of mastitis actually pretty quickly. So mastitis is going to look kind of adenomous under ultrasound. We're going to see fluid within the area of pain. The breast itself is going to be red, and it's going to be warm to the touch. This is a very common occurrence in women who are breastfeeding. It happens when a duct gets blocked, and then all of that milk kind of backs up and starts to cause problems. Bacteria get in and cause some havoc. So this is probably the one thing that you will actually scan through the ER. If you have a breast center associated with your hospital, you probably won't do most of the other scanning. An abscess then is something that can be sequela to mastitis. If the mastitis doesn't respond to antibiotics, or if the patient ignores the symptoms of mastitis, then an abscess can occur. And an abscess is just a collection of pus. The body has kind of walled it off because it doesn't want it to spread further into the body. Maybe we have a patient who started antibiotics and then just wasn't consistent with them, or maybe they weren't the right antibiotics for their mastitis, and they come back with even more pain. They come back with a focalized area, and we put the probe down, and we're going to see again this collection of kind of junky looking fluid in the area that mastitis was once diagnosed. If we put color on, we'll typically see lots of color around the periphery of the area, with the internal part not being vascular. So another benign finding that we have are the Cystosarcoma Phyllodes. And the Phyllodes tumors are pretty rare, but they're a little tricky because they have the chance to turn malignant. So most of them are benign, about 70% of them are benign, where about 30% of them are going to turn malignant. We find these in patients that are in their 50s, and their appearance on ultrasound really depends on the size of it. So small Phyllodes tumors are going to appear very similar to adenomas, where they're going to be isoechoic to the breast tissue, solid, well encapsulated. As they get larger, they're going to go through a few changes, and they're going to turn a little bit more hypoechoic. They're going to be hypoechoic with some internal echoes, and we're no longer going to have that through transmission or posterior enhancement behind it. Now, the size of the lesion doesn't necessarily dictate if it's going to be malignant or not, but if we see something like these, we should probably biopsy them just to rule out if this is Phyllodes that is malignant or benign. The next benign pathology that we have is the intraductal papilloma. And a papilloma is basically just a little ball of tissue, and we can kind of think of it almost as like a polyp within a duct. And these are typically benign, and we're most likely going to see them in the ducts behind the nipple. These are probably a little bit scarier for the patient because one of the clinical symptoms for them is that there's bloody discharge. So, if you're young and you have blood coming out of your nipple, that's a little scary. And so what we will do then for these patients is have a mammogram, and then we'll do an ultrasound, and what we'll see is going to be a dilated duct, most likely, with something inside of it. Now when we go through the malignant chapter, you'll see that there is a similar appearing ductal cancer. And so we want to make sure that we're putting color on these. And if there's no real vascularity seen within this area, then we can lean a little bit more to the benign side. Chances are, though, this patient's still going to get a biopsy. We may have missed that little tiny vessel. We may, there's just no proving what this is. And so we'll want to make sure that we biopsy it to confirm what it is. So our last benign pathology is one that affects males, and it's called gynecomastia. And gynecomastia is not the same as just having extra fat on the chest area in the breast area on males. This is actually a dilation of the retroareolar breast tissue in males. So they're going to look like they have kind of like a little mound of breast tissue sitting on their chest. These tend to be relatively tender for the patient, and they're going to feel like a firm mass behind the nipple. Now, gynecomastia can affect multitudes of ages of males. It can depend on hormones that they're taking, especially in males that are going through puberty. They've got lots of testosterone running around. There's more of a chance to develop it in patients who smoke marijuana. Postnatal males, we see this quite often in the children's hospital. They just have larger breast tissue, and that's going to be mostly from mom's estrogen. And then we see it again in older males. If this is a cancer-producing tumor, then we're going to want to run some blood work. We're going to see that their blood work is going to have increased estrogen, which isn't typical for males, or might even have positive beta-HCG, which also isn't common for males. So you can see here, it's going to actually look like breast on a male, and it's going to be the increase of fat under that subareolar area. On ultrasound then, we are going to see a hypoechoic, kind of triangular pyramid looking area underneath the nipple. All right, so that's the end of our benign pathology. Again, take the time to learn each of these pathologies, learn the patient's symptoms, the age groups that they affect, and try to kind of visualize who that patient is and what their ultrasound will look like. You'll have some practice with this in your workbook. The other thing that I really want you to focus on is just in general, what are the benign characteristics? Round, smooth-walled, wider than tall, anechoic to isoechoic to hyperechoic. Okay? Those are our main benign characteristics. Memorize those.